All right. Thank you so much, everyone, for joining us today for the University of Chicago regional session. We are so excited about this breakout meeting that's going to be from 3 to 4 o'clock Eastern Standard Time. And so first up, we have Dr. Turaga. And for those of you who didn't join us for the general session, I'm going to just do a brief overview and introduction of Dr. Turaga. Dr. Turaga is an associate professor of surgery and director of the Regional Therapeutics Program at the University of Chicago. He's a special interest in the treatment of advanced malignancies, including metastatic cancers. He is an expert in regional perfusion, including HIPEC. So I want to welcome Dr. Turaga. And if you are joining us today, please just make sure that you are on mute unless you are presenting. Thank you so much.
Thank you, Lauren, and thank you everyone for joining us today. I hope you had a really nice session this morning. This afternoon session is supposed to be a little bit more personal, a little bit more intimate. You hopefully will get a flavor of what our clinical program is like at the University of Chicago. You get to hear some talks from all of our team members and kind of get a flavor of how dedicated everyone is to finding a cure for appendix cancer, and for those that we can't cure it, to figure out how to manage this disease as best as we can. So it's my pleasure to welcome all of you today. Feel free to ask questions. Lauren is going to help moderate this for us, and then we will have recordings of all the sessions as well. So feel free to reach out if you have questions about anything that we spoke about either this morning or otherwise, and in any way that we can partner with you to either make your personal or your caregiver journey better, or certainly to think more about the disease in general. So I welcome all of you this afternoon, and I think Lauren, if it's okay with you, we can get started with our first speaker, Dr. Ang.
Yes, sounds good. Thank you, Dr. Turaga. So first up, we have Dr. Ang, who's a double board certified surgical oncologist who focuses on the treatment of cancers in the abdomen, and in particular, cancers that have spread to the peritoneum. He specializes in CRS HIPEC, treats a variety of abdominal cancers, and is skilled at minimally invasive approaches. So please welcome Dr. Ang.
And thanks everybody for the opportunity, especially to the ACPNP, to give this talk. There is a little bit of overlap with some of what we had discussed earlier, but there are some other things which I included, which I think that are certainly unique to our program and things that are on the horizon in terms of management of these difficult cancers. Let's see. Okay, these are my disclosures. And so first, we'll just talk briefly about surgery for appendix cancer, an overview of cytoreductive surgery in HIPEC, and also how we do it. And then I'll provide some updates in management, as well as a few slides on ongoing research that's being done in this space. So surgery for appendix cancer, let's just take a step back and look at the fact that there are different types of appendix tumors. And as we went over in the main session, I mean, these are just most, but probably not inclusive of all the types of appendix tumors that do exist. And so, as you can imagine, given that there's so many different types of appendix tumors, it requires multidisciplinary team decision making based on, like we've talked about, the biology of the tumors. Have the tumors spread or have they not? And all these factors considered, that's why being treated at a center that sees this on a regular basis will help maximize the care that you receive. And so who gets surgery for appendix cancer? Well, we try to think of it as, is it localized disease or is it advanced or metastatic disease? And we hear the term peritoneal metastases, pseudomyxoma peritonei, which are sequela of appendix tumors. And so, again, just to emphasize, this multidisciplinary team decision-making is important in this process. And so, what types of surgery are there? And this is an illustration of an appendectomy, where this big thing here is a cecum, which is the first part of the colon, and then the small intestine coming right into it. And as I tell my patients all the time, the appendix is like a little party balloon that hangs off where the cecum is, and that's how it's really taken off, either with stitches or with staples, and we cut off the blood supply and the appendix itself, and that is an appendectomy. And in most instances, that's able to be done laparoscopically or minimally invasively nowadays. Now, for certain types of appendix cancers, it actually requires removing that portion of the colon that the appendix arises from, because they share a similar distribution of lymph nodes and part of the blood supply as well. And so certain cancers require that that portion of colon be removed to accurately stage a cancer to get enough lymph nodes where it's accurate and helps us make a decision about whether or not there are other therapies like chemotherapy that you would need to help treat the cancer that you have. And in this situation, when we take out part of your colon, the plan is to reattach part of your small intestine to the remaining colon that's there. Now, this is just an illustration of peritoneal metastases. In particular, this is pseudomyxoma peritonei. And so, what is done in that situation is what we've been talking about for most of the day, which is cytoreductive surgery, and HIPEC is another element that is in tandem with it, but separate. And so this is just a brief overview of the fact that cytoreductive surgery has actually existed for the better part of the last century. And the first cytoreduction for ovarian cancer was actually done in the 1930s. It was actually in the 50s and 70s where the improved survival was started to be seen with cytoreduction itself. And the advent of HIPEC started in the 80s, pioneered by Dr. Sugar Baker, and in which he wrote a landmark paper in 1995 about how he does the peritonectomy procedures. Again, cytoreduction, and we abbreviate that as CRS, it encompasses the surgery that's done. So these are some of the organs that are involved in cytoreducing tumors, whether we actually take out part of these organs or we actually clean the tumors off these organs, are dependent on the types of tumors they are, how stuck they are, and what we actually find at the time of surgery, which makes it difficult to really predict a lot of times what we're actually going to have to do. And so it seems like sometimes I tell my patients that I'm being vague when we talk to you in the office about these procedures, because honestly, we have to prepare you for a number of different things that could happen, but we don't actually know in many instances what we're going to see when we actually enter the abdomen. And a large part of that is our limitations with the imaging that exists nowadays. And HIPEC is one part of this whole package, but it is separate. So there are times we do cytoreduction without HIPEC, and sometimes cytoreduction with HIPEC, and in some patients that we had talked about in the main session, just HIPEC on its own. HIPEC involves a perfusion system where the abdomen during surgery is temporarily closed, and the abdomen is filled up with fluid. Usually it's either saline or something like lactated ringers, and it goes in and out of this perfusion machine at about anywhere close to 700 milliliters to a liter a minute. And at that point, once the circuit is working, it's heated up, and the chemo is dropped into the circuit and perfuses in that manner for a duration of time, which is dependent on the kind of cancer that you have. And so how do we do cytoreductive surgery? And this is a great paper that was published by Dr. Turaga a couple of years back. And so if you have a chance to look it up, it's in the Journal of Gastrointestinal Surgery. It actually illustrates what we see. So this is looking down from a bird's eye on someone's abdomen, and what you see there is actually the lining of the abdominal cavity, which is the peritoneum. It's actually been mobilized off of the abdominal wall, and so that is the lining that is on the inside. So like the illustration or the analogy rather we use is the paint on the walls of the abdominal cavity. And I admit that I took that from Dr. Turaga because I was saying something else beforehand, but this is so much better. So I have to credit him for coining that term for me. And so, that is the lining that encompasses the paint on the walls of your abdominal cavity. So you can imagine when you can take off the paint from the walls, but in many instances, the walls are still there. So, the paint on the diaphragm can be taken off, but the diaphragm is still there. So you can see here this is on the left side of your abdomen where your spleen is, and your diaphragm and your pancreas are there. This is where the peritoneum was and where tumors were, but now are not. So in many instances, we try and spare as many organs as possible during these procedures if we're able to take out the tumors in an effective way to treat your cancer. These are just more illustrations. Now, this is on the right side of the abdomen where the liver and the other side of your diaphragm is, and your kidney and adrenal gland on this side as well. And then again, this illustrates the ability to take the tumors off the pelvis. But again, sometimes it requires a bowel resection during this process. But again, there are many times we're able to do that without taking out part of your intestine. This is a photo from an article which demonstrates different ways that HIPEC is done. Some it's called the open technique or a Coliseum technique, and what we do here those is in figure B, where we actually, it's a closed technique where we have the catheters going in and out, and we temporarily close the abdomen during this point in time. So, what are some updates in management since the last couple of years? I would say that something that we like to talk about here that Dr. Turaga spearheaded is the Chicago Consensus Guidelines for Peritoneal Surface Malignancies. And so Dr. Turaga was able to corral all the experts in the country back in 2018 to get together and start brainstorming how we would provide a consensus document which serves as a beacon, not just for appendix cancer, but all cancers, or at least most cancers that have peritoneal metastases, to provide an evidence-based consensus guideline for not only physicians in institutions academically, but also across the whole country, and really consolidate the data in a way that can provide clarity on how to manage these complex situations. And so again, these are all published now, and you can actually, this is just one algorithm that's published online with appendix cancer, where we actually have demonstrated, based on the data, a flow diagram of our approach, which we all have agreed upon with this national group, on how to approach cancers such as appendix cancer. And since the publication of this, we have said that this is really reflective of the standard of care in this disease process. And so again, it's about providing documents to summarize the data, but also provide education for physicians who probably don't see this very much, and can actually read something that's tangible and summarizes the data in a way that makes sense. And what's also important in the process of undergoing these big surgeries with cytoreduction and HIPEC and these complex disease processes is the fact that not only is the decision-making of when to utilize surgery versus chemo or not important amongst collaborating with different specialties, but also the multidisciplinary care that is required to emerge from these surgeries successfully and to move on to the next step in treatment, whether that's observation, whether that's chemo or something else. And so we wrote about our experience here, and what we have is called an enhanced recovery pathway, which enhanced recovery is basically utilizing multiple modalities of care, multiple specialties together to ensure the best outcomes. And so these are, again, this has been published this past year, and we incorporate many aspects of our multidisciplinary team to optimize patients before surgery, immediately. So during surgery, immediately afterwards, and even in the weeks that ensue after you're out of the hospital and home. And so again, this is just one reflection of that. But the fact of the matter is, from before getting into the hospital, things to do right before an operation, things we pay attention to in the operation, and then afterwards are all aspects of care which matter equally to ensure that, again, you have the best outcome after a complex procedure such as this. The other thing I would like to touch upon a little bit is ongoing research. Again, this has been talked about by Dr. Line, is that we're starting to understand more and more about what makes, what the sort of genetic makeup of these tumors, what are the mutations that are most often, occurring with these tumors, and that helps us guide the way that we think about therapies going forward. This idea of precision medicine, personalized medicine. This is the next frontier in this disease process, and this is something we are working towards here at the University of Chicago. And again, these are data that have been published profiling the fact that these appendix tumors do behave differently than colon cancers, because they used to be thought of as the same thing, but now we know there are different tumors altogether. And so some of the ongoing research we have here at the University of Chicago is trying to understand, are these tumors, are all peritoneal metastases from these tumors the same? Is the tumor that's sitting in one area the same as the tumor sitting in a different area? And did maybe one get to one area first? Does it matter in the long run? Can we change actually the makeup of these tumors molecularly with HIPEC? Can we use HIPEC as a tool to change the way these tumors are, the way they behave? and certainly what does this all mean in the long run. And so we are very fortunate to be undergoing research right now that's funded by the ACPNP. And so we hope to have some interesting results from the research coming in the next probably 6 to 9 months. And so certainly we will keep you updated as these things develop. Please feel free to contact me if you have any additional questions, and thank you very much for your time.
Thank you, Dr. Ng. That was a wonderful presentation. Next up, we have Emily Fenton, who is a physician's assistant for 6 years, and she's been with the Regional Therapies Program at the University of Chicago for over 3 years, furthering the oncology field through research, public speaking, precepting, and participating in task forces aimed at improving patient care and access to care. So please welcome Emily Fenton.
Thank you. Today, my talk is entitled Managing Cancer, Leveraging Your Oncology Team, Keep Cancer from Managing You. And today I'll be talking about some ways to navigate the cancer journey. This is based on my own professional experience as a surgical oncology PA. It's based upon my own interactions with patients, and I'm hoping to be able to provide insight to patients who are listening today to feel more in control of their cancer care, more knowledgeable of the standard processes we use, and the resources that are available to you. I'd like to address the common issues I see, and as well as some strategies you might use within the different phases of cancer care, starting with the phase of diagnosis. So in this initial phase, you receive that diagnosis that frankly can be both frightening and often feel very foreign. And this can naturally make you feel overwhelmed to navigate that. And the stack of unknowns before you, I think, commonly leads to patients experiencing a sense of urgency. So I want to talk today about some ways to alleviate this sense of urgency. First, you need to select an oncologist. Your primary doctor is a good resource who can provide referrals to you, or you can seek out a center that is NCI designated or National Cancer Institute designated. In general, for all cancer diagnoses, the more rare your diagnosis is, such as appendix cancer, or the higher the stage, such as stage 4, the more strongly I'd recommend seeking an opinion of care at a high volume cancer center who have oncology teams that specialize in your cancer type. Developing knowledge and understanding of your cancer diagnosis takes time. So I would wish all patients who are newly diagnosed with cancer to know to be kind to themselves and allow that knowledge to develop over time. I actually think the easiest and fastest thing to do is to develop a plan of action. So let's walk through that. During your visit, your oncologist will need to have all relevant information to make a care plan for you, including operation reports, pathology reports, CAT scans, MRIs, or PET scans. And it's critical that your oncologist has up-to-date physical imaging to review and not just those reports. Additionally, large cancer centers often want to confirm your diagnosis is correct. And so this requires institutions, pathologists review your actual pathology slides, and this can often take up to 7 days to complete. Having all of that relevant information available is essential to creating a complete treatment plan for you. So I would suggest creating a binder with your records, make a habit of asking for a CD of any imaging you have done at locations outside of where you receive care. With incomplete information, you can still expect to obtain a partial plan of care by the end of your initial visit, but most oncologists will not take significant steps, such as proceed with chemotherapy or surgery until all of the required data is available. In addition to meeting your oncologist, you may meet other members of the oncology team, so you should expect that initial visits could be up to 2 hours long. In terms of setting a realistic timeline, it's important to know that delays in finalizing your oncology plan are very common. It's our job to be thorough, and there is no data to suggest that a delay of 2 to 4 weeks in order to secure appropriate imaging or confirm the correctness of your diagnosis and pathology, or to prepare for and book your surgery, that these things will significantly alter your outcome, and it allows you time to prepare. Every instance is specific though, so I encourage you to just ask your doctor about what timeline is safe, what's expected, and we work together to finalize your cancer plan as soon as possible. Once your care plan is developed, the next step is to start treatment. And depending on your circumstances, you could be recommended to undergo upfront surgery or several months of chemotherapy. Undergoing chemotherapy is very demanding on your schedule. And surgery often requires several days in the hospital, followed by several weeks of recovery, which again impacts your ability to participate in daily activities or feel well for some time. This phase requires the most intensive amount of support. And I'd like to quickly highlight what support is available to cancer patients from our perspective, and some pearls I'd want all cancer patients to know while undergoing treatment. It's important to know who your oncology team is. At different times during your cancer journey, either your medical oncologist or your surgical oncologist will be leading your care. Each oncologist is generally supported by more clinical staff, such as advanced practice providers, nurses, or care coordinators. If you're ever unsure what oncologist is leading your care or what role each member of the team plays, it's absolutely okay to ask. Most cancer centers also offer a multidisciplinary team and provide many resources to comprehensively address the common issues that can arise during cancer treatment. And I've listed some of those services on this slide. My greatest advice to patients is to be proactive by mentioning your concerns early. It is much easier to prevent a serious problem by addressing it while it is still a mild or a moderate one. And it is important to listen to your body. Let your providers know if you're experiencing symptoms such as poor appetite or weight loss, declining physical strength, pain, intestinal symptoms, or other issues, and ask your providers to help you address these types of symptoms early so you can feel as well as possible. My second observation and suggestion is to address your mental state. Everyone processes a cancer diagnosis differently, but it is extremely important to recognize the impact your diagnosis has on your stress levels, mood, and ultimately your body. As stigmas decline around mental health and talking about mental health, I ultimately wish every cancer patient would have access to and seek out the right type of support for them, whether this is through professional services or community resources, church support groups, family. For those of you who prefer autonomy, I suggest apps or websites that may guide you through mindfulness or meditative sessions. And certainly, if you don't already, I encourage you to take advantage of organizations that support your specific cancer diagnosis, such as the ACPMP, which fosters community and relationships among people who have a shared experience. I encourage you to find optimism and hope in each day, find ways to reduce your anxieties, and consider this an important component of your cancer treatment. So I was talking about preparing for surgery, and I'll jump back in there. I wanted to spend a few moments talking about surgical preparation. Preparation for surgery maximizes your chances for an optimal surgical outcome. That means every little effort that you make counts when it comes to surgery day. As medical providers, we will work with you to make sure your medical issues are stable, but what can you do? The keys to maintaining your health are via, you won't be surprised, diet and exercise. This is how we nourish our bodies, we maintain our strength and vitality. And the goal is to be as well and as healthy as you're able to be. Of course, there's no perfect cancer journey, and there will be days you don't feel well or that you're not able to meet the goals you may set for the day. However, the goal overall is to avoid declining health as a result of your cancer or as a result of cancer treatments. I think being proactive in maintaining your nutritional health is also extremely beneficial and important to minimize postoperative complications and ensure a quick recovery from surgery. So it's our routine practice for our oncology dietitian to follow every patient through treatments, both before and after surgery, to prevent declines in nutrition and ensure your body is strong enough, not just to undergo surgery, but also to recover well from surgery. I believe exercise is a very powerful weapon against fatigue, weakness, mental fog, anxiety, depression, and it helps your body fight your cancer. It's safe to do and it's important. I encourage you to get specific. How many minutes a week would you like to exercise? What exercises or activities work for you? If you're having difficulty defining the right goals for you, A physical therapist may be able to help, and that's available at many cancer centers. And specifying these goals helps them to become a reality, empowers you, and again, is another important component of surgical readiness. If you experience a recurrence of your appendix cancer, surgery or IV therapy, again, become options. And in today's medicine, the genetic information of your tumor, called next generation sequencing, has become a critical data point that your oncologist will use to identify better ways or drugs to treat your cancer. Some examples include Foundation 1, Guarded 360, Tempest, Oncotype, and many more. Cancer recurrence can, of course, be an especially challenging time. It's normal to feel disappointed. Remember that all of the cancer treatments that you've already completed were done with the hope that your cancer wouldn't return, but also kept the cancer at bay until this moment. And if your cancer does recur, it can be useful to seek second opinions to gather information about what advanced treatments or clinical trials each institution may have available. Virtual platforms have made it easier for patients to seek care from physicians across the nation. At the University of Chicago, we offer the ECO program, or Express Expert Cancer Opinion. This is a preliminary conversation with your preferred doctor to discuss potential treatment options, typically while we are waiting for your complete records to arrive. And then you can typically schedule a subsequent formal visit after records have arrived, and where the doctor can give you a more comprehensive and personalized assessment and treatment plan. International or distant patients may also choose to pursue a remote second opinion, which is a self-pay option to receive a comprehensive opinion. And finally, we offer virtual visits for ongoing care of patients who live in the surrounding states in which our physicians are licensed to practice. Survivorship is another phase of cancer care, and survivorship can be defined in many ways, but every person with a cancer diagnosis is a survivor. Another way to think about survivorship is the period of time after intensive cancer treatment where you learn to reacclimate to and return to a more normal way of life. During this time, you will still require ongoing surveillance, usually with CT scans or MRIs, blood work, such as tumor markers and a physical exam, but these visits are much less frequent than they were during your cancer treatments. Many patients or many programs offer a survivorship clinic or ongoing palliative care symptom services, which may augment those surveillance visits by also addressing some of those lingering effects that remain as a result of your cancer treatments and help you come to the terms with the changes of your body. This is the time to focus on learning your new normal, do the things you enjoy, spend the time with the people you love. If you do have a recurrence, it happens during the survivorship phase, and it can come as a shock that can leave you feeling unprepared. So for this reason, I encourage you to approach your cancer like a chronic disease that has been treated and is under control, but that we have to remain vigilant about until we discover that cure for cancer. Again, I encourage you to address your emotional health through the survivorship phase. Utilize those resources that are available, and even consider mentally preparing for the possibility of recurrence before it happens. As promising new cancer treatments are being developed and placed into clinical trials, we can't lose hope that we will ultimately beat cancer. We do remain hopeful, and we strive every day to provide the best cancer care to each patient. I see the positive impact this makes, and I think today we've seen we are having more success in the ways that we can treat cancer than ever before. So thank you for letting me speak today. Sorry for the technical difficulties. Ultimately, our goal is to help you manage your cancer and keep cancer from managing you. Please let us know how we can help at University of Chicago. We will put our full arsenal of support and resources in to work and assist you through your cancer journey. Thank you.
Thank you so much, Emily. Up next, we have Jen Belansky, who is a nurse associate for the University of Chicago Regional Therapies Program. She's been involved with the program since 2019. She has 9 years of experience as a registered nurse in both the inpatient and outpatient setting. She supports patients at the University of Chicago throughout their oncology journey by providing education and assistance navigating their care plan. So please hear from Jennifer Belansky.
There we go. Good afternoon, everyone. One of my priorities as a member on this team here at the University of Chicago is to just ensure that our patients are knowledgeable about their disease process and their plan of care. Your diagnosis is rare, and you're likely to encounter healthcare providers along your journey who are unfamiliar with the diagnosis and the treatments that you're getting. So being educated will allow you or your loved one to be the best advocate for you. It can be intimidating to try to figure out where you should get your information from. And so today I'm just going to review a couple of the most popular sources for each patient. So every patient's initial and most consistent source of information is going to be their physician, whether that's your primary care physician, your oncologist, or your surgeon. They're going to be the person that you turn to with all of your questions and confirmation of what you've learned from other sources. Your second source of information is going to be the facility where you're receiving your treatments. This will not only overview your disease and your treatment plan, but also include facility-specific protocols or logistics. And then the last source that everyone will turn to is going to be the internet. Everyone will Google search their disease, but it's an endless amount of information, so navigating it can be very difficult. So I'm going to share with you some tips to help guide you through that process. The facility that you're diagnosed at and receiving your treatment will likely give you various handouts or documents to help you understand your diagnosis and the journey that you're embarking on with them for your treatment. Here at UChicago, we have a video that was developed a while ago that's on our website and also available on YouTube that reviews what a cytoreductive and HIPEC surgery is. Our team has also put together a nutritional booklet and a surgery education booklet. On the right side of your screen here, you can see just the first page of our surgery education booklet. This reviews what cytoreductive and HIPEC surgery is and the diseases that it is typically used to treat. But then it also will dive into the pre, intra, and post-operative stages of your surgery. In the preoperative stage, the booklet will list the various labs, tests, or appointments that we require prior to anyone going in for surgery. Something that might be specific for our facility is that we have most of our patients meet with a palliative care physician prior to surgery to establish care with her, develop their goals of care, and hope that our surgical process is in alignment with the patient's goal. She'll also help manage symptoms both pre and post-operatively for our patients. In the intraoperative section, it reviews all the different procedures that can be done during surgery and then how that will impact your care moving forward. For example, if an ostomy is going to be made, it explains how your diet will likely have to change, or if you're going to be receiving a splenectomy, reviewing that you're going to need vaccines both pre and post-operatively. And then lastly, the post-operative portion reviews the most common symptoms our patients can expect to experience after surgery and how our team manages those. It will also review some post-operative care that we expect of patients, one of which is Lovenox injections for 28 days after surgery. So patients can anticipate preoperatively that they're going to have to administer these injections to themselves post-operatively or have a loved one do it for them. It also goes into detail about how we prefer that our patients stay local for at least a week after their discharge after surgery, so that our team is the one to help manage any concerns or complications after surgery. All facilities will have some version of this kind of education for their patients receiving treatment or surgery. If you're a non-UChicago patient, we're happy to share this with you as an extra resource, so please feel free to reach out to us. The largest and sometimes most difficult area where you're going to be finding your education is the internet. So the first thing that you're going to need to do is identify the type of content that you're looking for. If you're looking for medical or research articles, your best websites are going to be .gov or .edu websites. These articles are going to be heavy with medical terminology and the scientific method. So if that's something that you're interested in reading through, it'll likely include all of the data. It can be lengthy to read through. Those are going to be your best websites. The first thing you're going to want to check on these is the date of publication. So because this is a rare diagnoses, the treatment for it is ever changing. So you want to make sure that it's been published within the last 3 years and no more than 5 years old if you're looking for new or available treatment options at the moment. You're also going to want to make sure that the author is credentialed to be writing about this topic. If you're looking for more of a broader overview of what those outcomes were of those research trials, or just more general information about your diagnoses, you're going to turn to the .org, .com, and .net websites. These will also be good resources for you to read other patients' journeys or connect with other patients who have the same or a similar diagnosis as you. The same with these websites, you're going to want to make sure that they have been updated recently so that you're getting the most recent content. And typically on these websites, you're going to go to either the very top or the very bottom where it's going to say the updated date. Again, follow the same rules of within the last 3 years and no more than 5 years old. And then lastly, you're going to take all of this information that you gained from the internet, and you're going to bring it back to your physician and review it with them to not only make sure that you're understanding what you've read correctly, but making sure that it's something that is applicable to you, your disease process, and where you're at within your journey. Sometimes patients will find things on the internet that is happening right now, but unfortunately it's happening in a different country. So ensure that what you're reading is something that's available to you in the States. Again, bring it back to your physician and they should be able to help you understand if this is something that is available to you here. I hope that you're able to take some of these tips and tricks with you and feel a little bit more confident when you're researching your diagnosis. And I hope that you can reach out to me in the future, whether you come to UChicago or not, and I can be an added resource for you.
Thank you so much, Jennifer. And so we're running a couple minutes behind here. I just want to let everyone know who is tuning in today. But up next, we have Julie. And Julie is a patient at the University of Chicago, and she will be sharing her patient experience with everyone today. So please welcome Julie. Oh, hang on, Julie. You're actually muted. So if you go to the bottom left-hand corner, yeah, there you go.
Good afternoon, everyone. My name is Julie Rittenhouse, and I would like to thank Dr. Turaga and his team for this opportunity to speak with you today. I would like to begin with an overview of my cancer journey, followed by a brief reflection on what I have learned thus far. I am 64 years old and live in Cleveland, Ohio. I work in higher education as a fund development director and an adjunct professor in urban studies. This past spring, I was diagnosed with appendiceal cancer stage 4. I had never heard of this type of cancer, and I quickly learned that this cancer is rare and often can be diagnosed as another type of cancer. In mid-January, I began to experience abdominal discomfort, and I knew instinctively that this was not normal. In fact, the pain was acute at times. I made arrangements to see an internist. 2 weeks later, I met with an internist at Metro Health. Metro Health is a nationally ranked public healthcare system in Cleveland. It is one of the 3 major healthcare systems in Cleveland, along with the Cleveland Clinic and university hospitals. Based on my presenting symptoms, the internist scheduled blood work, a CAT scan, and a colonoscopy. Until this time, I was a healthy, active person who had no pre-existing conditions, took no prescription medications, and had no major surgical history. My internist told me that I was his healthiest patient. I wondered to myself if perhaps it was diverticulitis. My youngest brother had been diagnosed 2 years earlier and had successful surgery. The CT scan showed an inflamed appendix, and I was told I would probably need an appendectomy. A few days later, the colonoscopy showed results. No polyps. However, a small lesion was found on the cecum, and in an abundance of caution, a biopsy was taken. 3 days later, I was informed that the lesion was malignant and a right hemicolectomy was recommended. I met with the surgeon the next day. During the visit, it was explained to me that my diagnosis was treatable. There would be no staging of the cancer until after the surgery, and there was a possibility of the spread to the lymph nodes. If this was the case, I might need chemotherapy treatment following a recovery period. Once the surgery began, it was quickly aborted due to the spread of cancer to the peritoneum. My surgeon took a biopsy and consulted with a colleague at the Cleveland Clinic. The surgeon at the Cleveland Clinic agreed to a consultation, and 3 days later, I was in his office. During the consultation, I learned that I most likely had appendiceal cancer stage 4, and the recommended course of treatment was chemotherapy, followed by cytoreductive surgery and HIPEC. Arrangements were made to meet with a highly recommended oncologist by week's end. It was during this meeting that I learned that my diagnosis was terminal, with a 2-year survivability rate. And if the recommended chemotherapy treatment worked and I was a candidate for surgery, then perhaps 3 more years. It was only after this consultation that I realized the grim reality of my medical condition. Second opinions are critical. My sister Amy, a nurse, immediately began an exhaustive research of my medical condition. She learned through multiple sources, including the Cleveland Clinic, about Dr. Turaga, a leading researcher and surgical oncologist at the University of Chicago. Chicago was a logical choice for me to consider because I have family in the area. I grew up in South Bend. My sister and I agreed to make a quick trip to Chicago for a consultation. Before the trip, however, we encountered a problem with insurance coverage and were informed by a staff person in the finance department that my insurance would not cover the UOC consultation and future medical care. I was distraught. At face value, it did not seem to be accurate, and my sister doggedly pursued the matter and learned that I was indeed covered. Do not take no for an answer. On May 11th, my sister accompanied me to my consultation with Dr. Turaga and his multidisciplinary team. In preparation, we watched all available videos and compiled a list of questions. Upon meeting Dr. Turaga, his first question to me was, "Please tell me about yourself, Julie." I was so surprised by his icebreaker question that I struggled to answer. Clearly was he not only a skilled surgeon, but also an empathetic man. As I huddled next to Dr. Turaga to view slides on the computer screen, he walked me through his assessment of my medical diagnosis. At one point, I recall saying, "No one ever told me that." I then turned to look at his 2 medical residents in the room, and one of them said, "He sees things that no one else sees." At that moment, my head and heart told me that I was where I needed to be, and if Dr. Turaga would take me on as a patient, I would transfer my care to him and his team. With no false modesty, Dr. Turaga responded that he knew what he was looking for, and he began to outline a treatment plan for the next 4 months. This was followed by meeting his team, nurses, physician assistants, a nutritionist, and oncologist, Dr. Shergill. Commitment to the treatment plan. The very next day, I began my first round of chemotherapy at the Cleveland Clinic. No time to waste. I made arrangements to transfer my care to the University of Chicago, informed my employer, and moved temporarily to South Bend, and I commute to Chicago for all my treatments and surgery. Over the summer, I completed 6 rounds of aggressive chemotherapy and was cleared for surgery in late August. The surgery, which included a right hemicolectomy, cytoreductive surgery, and HIPEC, was a success. However, as added insurance, both Dr. Turaga and Dr. Shergill recommended another 6 rounds of chemo that began this past Tuesday, followed by CT scans every 3 months. One cannot do this alone. Throughout the past months, I've been supported by the extensive cancer care resources at the University of Chicago, a loving family, and dear friends. At every step, I've been met with much kindness and the best of care. I have learned a new lexicon. In managing the logistics of my treatment plan, I strive to practice an approach of trust but verify. As a single woman, my brothers and sisters and their respective few weeks post my aborted surgery and the first day of chemo in early May, I felt Dr. Turaga and his team, the fog lifted and our collective spirits were raised. We were on a mission, and guided by my sister and my other brothers and sisters, I traveled near and far to care for me every chemo week. When all is said and done, they want to report on who is the best caregiver. They are all wonderful, and I will never tell. And yet, I felt like a burden. I'm an independent and self-sufficient person, and as much as they told me I was not a burden and I would do the same for them, this was an issue I struggled with the most. And now, at times, I must continue to work at shaking that feeling. Being vulnerable with family and friends and letting them do the smallest and most significant task for you is a new experience for me. Humor is the secret sauce. Throughout this process, I know that so much of getting well depends on your social network, and I am blessed. Friends and neighbors are taking care of my home and continuously offer other forms of assistance. For me, work has been a saving grace. I have continued to work remotely throughout my treatment because I want to, and it provides me with a sense of normalcy and a connection to colleagues and students. That said, my number one job is my well-being. My otherwise excellent health has served me well thus far, and I must maintain my physical strength through good nutrition and exercise so this continues to be the case. From past experiences, I have demonstrated strength in dealing with life's disappointments and sorrows, but I wonder if when I return home and life in Cleveland, that I might need another type of support, perhaps a support group of cancer patients. I don't know. However, I am confident that I will tap this type of support and other resources as needed. As I begin this next round of chemotherapy, I am somewhat anxious because I know what this type of treatment entails. When I began chemo in the spring, I was blissfully ignorant and determined to be positive and unfailingly polite. I was quick to give a thumbs up and a smile to everyone I encountered. It is my fervent prayer that I can continue to be positive, but I now recognize that if I fall short at times, all will be well. When the next round of chemotherapy ends in late December, I fully understand that my journey continues. Like so many cancer patients, I must reach the magic 5-year mark. I have pledged to myself to continue working on being comfortable with uncertainty. As a person of faith, there is always hope, and I remain hopeful about my long-term prognosis. I am most grateful to all of you who gathered for today's symposium. Thank you.
Thank you so much, Julie, for coming on and sharing that. That was wonderfully well spoken, and I'm sure so many attendees today can take away and resonate with a lot of the feelings and things that you discussed during your talk. So thank you again for coming on and sharing that with all of us. I now want to introduce Jeffrey Whitridge, Sarah McRaig, and Sandy Clark, who will be coming on to talk about preparations that you didn't know you had to do.
Trying to share my slide.
While Jeffrey's pulling that up, I can just kind of chat really quickly in the meantime, because I know we're a little short on time. I'm Sarah, one of the physical therapists that works with Dr. Turaga and Dr. Eng. I have another co-physical therapist, Maria Alvarado, who she specializes in lymphedema rehabilitation. And a lot of times, depending on where surgery can occur, some lymphatic systems can be involved, which can result in some edema and some swelling in the legs, which that's something that Maria can help assist patients with if they have questions and help coordinate care, especially like patients like Julie who aren't from the Chicagoland area, to try and help coordinate care close to home. I also specialize in pelvic floor rehabilitation. So if patients ever have concerns or have side effects from surgery with any bowel, bladder, or sexual dysfunctions, that's something that, again, we can try and coordinate locally, or if in the area, help with care with some exercise and getting some rehabilitation in that way. But the joint thing, which Emily had mentioned earlier in today's presentation, is just the importance of exercise, both cardiac and strengthening, and just optimizing your body before surgery, which will help substantially with outcomes and energy levels post-surgery. So we try to meet with patients to discuss current activity levels. And as Emily had mentioned before, if you don't like to do it, you're probably not going to do it. So trying to coordinate some customized care in a way that will help motivate patients and get you excited to try and move, especially on days where you are feeling a little bit crummy. So those are some things that we focus on from the physical therapy aspect of things. And Jeffrey, I'll take it over to you if you're ready with your slides.
And so, good afternoon. And today I'd like to talk about nutrition prehab and sorry about that. I'm just having a hard time getting to share the screen. And
We can see your screen, Jeffrey. If you
can
just
see
want to
it.
hit
Okay.
F5, you could
Okay.
probably get into presentation mode. Or if you click on slideshow and present,
I can't see that's part of the,
just slideshow at the top where it says home, insert, design, transitions, animation, slideshow.
well, I'm just going to keep going. So good afternoon. And I've been asked to talk about our nutrition optimization or nutrition prehab program. I like to say that Hippocrates said it best: let thy food be thy medicine and thy medicine be thy food. In today's language, it's called food as medicine. And so rather than go through all the components of a nutrition assessment, I find that it's important to talk about 3 questions that I will usually ask patients. How would you rate your appetite, good, fair, or poor? And second, do you think you're meeting your nutrition needs? And third, what do you think is the biggest barrier to your appetite or intake? Oftentimes, these questions are usually what can get a conversation or a dialogue going about nutrition impact symptoms. So when I'm providing this nutrition education, oftentimes I'll usually say to a patient, this feels like kind of theory until we get to the practical application. And so what happens is I will usually kind of go through and talk about appetite, a sense of feeling too full, uncontrolled nausea, the cold sensitivity, things like that, to see what are the main barriers for people eating. And then what I want to be focusing on is what I call eating strategies. And one of the tried and true methods that I use most often is the smaller frequent meals. Another one is usually using nutrient density, which is just meaning that you're using the same number of bites, but trying to get more calories in them. I oftentimes try to customize the eating strategy to increase the calories or protein. I can do this in typical and traditional ways, as well as whole food plant-based eating. But I think one of the most important things that I try to get across to a patient is the idea of protein loading. And this is where I'll usually individualize a customized eating pattern. And I'll often be saying protein, protein, protein. There's 4 good sources of protein. We'll also be addressing the use of those oral nutrition supplements like Boost, Ensure, Kate Farms, or Gain. And a lot of times I often hear that patients have already fatigued on those by the time I've come to using those. So this is where we'll be starting to use protein powders from whey, rice, or pea-based protein powders, where we can make them easy and tasty and kind of high calorie and high protein. I encourage those to be used about 7 to 10 days for consistent intake, hopefully translating into a pound or two of weight. So the use of smaller frequent meals, nutrient density, high protein oral nutrition supplements or protein powders are part of our enhanced recovery pathway program. It's worth letting you know that to get ready for your CRS HIPEC is kind of the same skill set that you're going to need afterwards. So kind of transitioning once we get through the 6 weeks, we'll be kind of talking about survivorship and surveillance, eating patterns. And it's our goal to be having you eating a regular diet as quickly as possible and no later than 6 weeks. We often focus on the Mediterranean eating pattern for its health promoting, anti-inflammatory, low glycemic, plant forward types of eating and healthy properties. And so oftentimes I just kind of focus on kind of simple and realistic goals rather than large overwhelming goals. And it's worth remembering that the successful behavior changes through eating and exercises usually take about 6 to 8 weeks and are not overnight. And those that want to go further, certainly we can talk about whole food plant-based eating. And again, I'd like to thank the ACPMP Planning Committee, my team, and Julie, of course, for the great work. Thanks.
Hi, I'm Sandy Clark. I'm patient care coordinator here at the University of Chicago. And I am grateful to be able to have an opportunity to speak to you about legal documents that are called advanced directives. All right, as I'm trying to, there we are. All right, well, an advance directive is a written statement that you prepare to spell out on how you want your medical decisions to be made in the future if you are no longer able to make them for yourself. They give you a way to tell your wishes to family, friends, and healthcare providers and who you want to make decisions for you when you can't. And this helps to avoid confusion later on. There are several types of advanced directives, as you can see on the screen. There's the living will, there's a durable power of attorney for healthcare, there's a POST, which is a physician order for life-sustaining treatment, and then there's also the DNR order. Today, though, I'd like to put more emphasis on the durable power of attorney for healthcare, because most healthcare professionals would like to at least know that you have that document. You have assigned someone to be the power of attorney for you for healthcare. This form does not require an attorney, but it does require the signature of a witness who is a non-family member. And a POA, the power of attorney for healthcare, is the form that you have identified someone to speak on your behalf if you cannot. There are several factors to consider when choosing a power of attorney for healthcare, a person to be your representative. This representative can be anyone you trust who is at least 18 years of age. And then you should ask yourself, is this person assertive? Is this someone that is comfortable speaking with healthcare providers and can advocate for you? Are they comfortable talking about death? Do they live nearby? And will they respect your decisions? There are several websites and resources available, as I think Jen had made reference to, regarding I don't know what happened to my slide, but let's see. Is it still there? Gone, okay. But there's websites and all types of resources and links, you know, to be able to get more information on the advanced care directives and for planning. And the final point that I'd like to make as we are closing is that know that advanced care directive planning is about making thoughtful decisions and choices and putting them into a written directive and discussing those choices with others. That's the key, that you would have conversation with your loved ones, with the decision-making, the person that will stand for you if you are unable to make those healthcare decisions. But preparation is key. Healthcare providers prefer to have it so that they know who to talk to in the event that you can't talk for yourself. So I thank you, and I don't know what happened again to the websites, but certainly feel free to reach out to me at the University of Chicago through Dr. Turaga's office, and I'll be happy to help you along that process.
Thank you so much, Sandy. So I just want to ask, Sarah, did you have a presentation or anything? Okay.
No, it would have been one slide. It wasn't.
Perfect. Okay, so I know that we are running a couple minutes behind. We did have 2 questions that rolled in. So if it's okay with the panel, I would like to just quickly ask those. I know your time is very valuable. So can we make mention of those? Do you guys have time? Okay, perfect. So one of the questions that came in was, is there anything I can investigate to reduce symptoms about the neuropathy in my feet?
That's a great question with a very challenging answer. Unfortunately, especially if it's chemotherapy induced, it's one of those things that once you're finished with chemotherapy, the nerves can then allow time to heal, which then will hopefully help with symptom recovery. Unfortunately, it can take a very long time, from months to up to 2 years, for some of those symptoms to come back. However, some of the things that we typically try to recommend for patients is to do something like, if you hold like stress balls or like curl your toes, anything to try to promote blood flow to the region. Hot packs very gently, making sure obviously you don't have a burn by any means, but basically trying to promote blood flow. So especially if it's for anything in the feet, we try to do some balance training as well to try to get those muscles firing. But I'm sorry to be the bearer of bad news. I wish I had a better answer.
Thank you so much, Sarah. So we had another question come on that said, my father-in-law has lymphedema, which is making exercising very difficult. What are some tips and suggestions for that? And also, is this common for appendix cancer and PMP patients?
Another good question. I am definitely not the expert, but from what I have learned from Maria, it can be common. It all depends on how things go with surgery. So if the surgery is extensive enough where any lymph nodes have to be removed, you are definitely at a higher risk for developing lymphedema. But in terms of recommendations for people who do have lymphedema in the legs, is I would highly recommend, you can obviously reach out to our team and we can try to connect. But the other thing is to get some form of lymphedema physical therapy, because they can do a massage technique to try to help educate both family members and the patient on how to do this massage to reduce size of the limb, to help decrease edema. And then more importantly is following up with some form of compression garment, whether it's a custom made compression sleeve that would be put on the limb, or these wraps that would also be administered as well, because once the swelling's more contained, exercise will be a lot more tolerated and blood flow won't continue to go to the limb. So compression garments and learning the massage technique are probably the 2 most important things to help manage the lymphedema care.
Thank you. So I know we're 8 minutes over. I want to say 2 more minutes if anyone wants to unmute themselves to ask a quick question. Otherwise, if you do have questions that you think of after the session, you can always send an email to info@acpmp.org and we can find a answer for you. So I'll give you 2 minutes if you have a quick question, or Dr. Turaga wants to come on.
I do. Lauren, and I wanted to thank all of the patients, family members, people that are interested who have joined our symposium today. I wanted to give a big shout out to my team, Angela, Jose, who helped coordinate this from our side, and of course from the ACPMP side, Carolyn, Lauren. So thanks for putting this together. You know, again, this is a journey. You don't have to feel limited by the duration of Zoom and time of a symposium. You know, we're all here to kind of figure this out together. And, you know, sometimes even we don't have answers for this, but we promise we'll try our best to help figure them out with you. So thanks again for your attention this afternoon. And thank you everyone for your dedication to our patients with appendix disease.
Thank you. Thank you, Dr. Turaga. Yes, thank you to all of the panelists that participated in the University of Chicago regional session. As Dr. Turaga said, please don't limit your questions just to this session. We always encourage you to reach out to your care teams if you have specific questions related to your needs. And like Dr. Turaga said, or may have mentioned, the regional session will be available. The recording will be available to those who missed out or tuned in late. So we will share the link to that where you registered, the same page, acpmp.org/virtual symposium 2021. Thank you again, Dr. Turaga, the entire staff and panel from University of Chicago, and we look forward to seeing you all very soon. Bye.